For those of you who have already joined, thank you very much for attending today. We'll be getting started in a few minutes. Good morning, everybody. Thank you for attending our webinar, Medical EmExome, a strategy for diagnosing patients with genetic disorders. My name is Lora Bean. I'm Senior Molecular Director at Emory Genetics Laboratory, and with me is Lindsey Mighion. The one that and with me is Lindsey Mighion, our laboratory genetic counselor. And we're going to tell you about the exome sequencing that we do at Emory Genetics Laboratory, and we're excited to share this with you. Lindsey and I are both employees of EGL, and this is a laboratory that offers fee-for-service testing, including the testing that we're going to be telling you about. So this morning what we'd like to do is briefly review sequencing technologies and how the EmExome has evolved. We're going to describe EGL's Medical EmExome and tell you what this testing includes and go through some decision-making processes about what testing options may be best for your patient and how you can make these decisions. We'll review the ordering process for the Medical EmExome, and our favorite part, we'll discuss interesting exome cases that we've worked on, and these cases will highlight both the successes and the limitations of exome sequencing. So I'd like to just briefly go back and remind everybody that even though next-gen sequencing has opened a world of possibilities in terms of how much sequence we can generate and what we can do for patients, there is still a role for Sanger sequencing in the clinical laboratory. So if we think about this evolution from single gene sequencing to gene panels to exome and then to even genome, we have to still think about what test would be right for patients. So let's take an example of limb-girdle muscular dystrophy. The most common form of limb-girdle muscular dystrophy is caused by pathogenic variants in the DYSF gene. Based on clinical presentation, possibly family history, there may be a good reason to go and test for this one gene first before going on and casting a wider net for testing. However, the presentation of muscular dystrophies can be nonspecific, and there are groups of genes that can put together on panels that can either be sequenced by Sanger sequencing as single or a small number of genes, or use NGS technology to do a gene sequencing panel. Examples of this include Bethlem or Ulrich muscular dystrophy, which are caused by pathogenic variants in 3 genes, and larger panels as well, such as congenital muscular dystrophies, which can be caused by pathogenic variants in about 25 genes. However, in a patient that has perhaps hypotonia, developmental delay, dysmorphic features, and maybe has already tested negative for some of the more common causes of this kind of presentation, casting a wider net may be what's most appropriate. So just to briefly review the evolution of sequencing. Our first generation, or Sanger sequencing, that everyone's familiar with, has its benefits. All nucleotides are interrogated. An analyst reviews the quality of sequence at every base pair, and for a long time it's been considered the gold standard, although at this point I think we can say that we're shifting to the point where NGS can be used as its own standard. There are limitations for Sanger sequencing, of course. Large deletions or duplications cannot be detected. There's a relatively high cost because it is labor intensive. Sanger sequencing is low throughput. There's limited automation that's possible in data review. And with any sequencing technology, there's potentially complicated interpretation and reporting of variants that we identify. As next generation sequencing has become available, we are able to take advantage of the benefits. Shown here is next generation sequencing data. The reference sequence is shown across the top, and the number of reads is shown down the bottom here. This very small number down here is 80. And each line is a read of sequence. And you can see over here that where there is a difference between the reference and this patient in about half the reads, instead of a GT in this position, you see a CT. This person is heterozygous for this GT to CT change. And as you can tell, from looking at data like this, that a high level of automation in reviewing this data is now possible. There are sophisticated bioinformatics processes that are available to do this, and we can generate and analyze a huge amount of sequence this way. There are limitations of this testing. The cost for the infrastructure to do this is high. Although the sophisticated bioinformatics techniques are a benefit, they're a limitation as well because you have to acquire those. The reagent cost is high, and again, you still have a complicated interpretation and reporting limitation, and in this case, it's amplified by the amount of sequence that can be generated. So let's go back and think about how you go about choosing the right test for your patient. I've given you the example of muscular dystrophies. You might want to do a single gene. There might be a group of genes specifically to go after, but there's other considerations as well. Is there a defined phenotype? Are there ambiguous or overlapping phenotypes? Or perhaps this is somebody without a clear presentation of something that is obviously a single genetic condition. We can think about these defined phenotypes as, is there a single cause? Are there multiple candidate genes possible? And depending on the number of candidate genes, this may fall back into the category of having a defined phenotype, or the overlapping phenotypes where casting a wider net is the best approach. Perhaps this is a phenotype where a specific candidate gene is not expected or can be suspected. And in each of these cases, in each of these scenarios, you can make a case for either doing a single gene test, an NGS panel, or going to a test like the Medical EmExome. It's very important to think about mutation spectrum. As I mentioned, large deletions and duplications are not going to be detected by sequencing techniques at this time. And if you're dealing with a clinical presentation that could be something recognizable, such as Duchenne muscular dystrophy, it's worth thinking about whether a deletion duplication test, which would account for a large proportion of the pathogenic variants in this gene, whether doing that type of a test first would make sense before going to a large sequencing assay. And if you think about your own areas of expertise, there are examples of genes for many different disorders where you need to think about whether sequencing will detect the majority of the pathogenic variants that may be causing a phenotype. Thinking about disease mechanism as well, it's not all variants that can be detected by sequencing. When we do a targeted panel for a particular disorder, we can really pay attention to what best captures the full mutation spectrum for that particular presentation. We can confirm variant calls if necessary. Perhaps array CGH for CNV detection is most appropriate as part of that panel. We can fill in missing bases and genes that perhaps didn't get sequenced well by NGS, but we know that that gene is important for a particular phenotype. We can make sure that those bases get covered by supplementing with Sanger sequencing. And Sanger sequencing is still the best way to assay genes that have pseudogenes. There's other complementary assays to think about as well. XLID and autism panels are commonly ordered. There are, of course, many patients with presentations that make this appropriate, but due to how common Fragile X syndrome is, it's important to remember that FMR1 trinucleotide repeat expansions are not going to be detected by next-generation sequencing, so you need to make sure that those assays are getting done as well. Other examples include the H19 LIT1 methylation and UP for Russell-Silver syndrome that can be included on a short stature panel, as well as UPD7 testing. And when you're thinking about something like Lynch syndrome, you want to make sure that you're specifically looking for deletions and duplications in EPCAM. PMS2 has a pseudogene, so regions of PMS2 are not reliably sequenced by NGS. That Sanger assay is necessary, and methylation assays may be appropriate as well. So these are all of the things that you want to think about in terms of what test is best, how clear a presentation does a patient have, and what assay should definitely be done for that individual. So understanding the limitations, again down here, what will be detected, what will not be detected, and what is best for the disorder that you're trying to rule out is always something to keep in mind, and it's certainly something that a laboratory can help you to determine if you have questions about that. So let's think about this exome sequencing. So in many cases, common causes have been ruled out, and it's time to go on to exome sequencing. So an exome is going to have targeted sequencing for about 22,000 genes. And that is a lot of genes, it's a lot of sequence, and it's a lot of analysis to do. But something very important to keep in mind, that there are previously about 4,600 genes associated with disease or GADs. This number is growing all the time. It's now over 5,000. So these are genes that have been associated with a medical condition, and variants in these genes can be attributed to causing genetic disorder. The other, about 17,000 genes, are genes of unknown significance, or gooses, and by definition, any variant we find in a goose is going to be a VUS. So if a gene has never been reliably associated with human disease, we're never going to be able to take a variant in that gene and diagnose somebody with a genetic condition. And so it's really these genes associated with disease that we want to focus on in this medical EmExome. So the medical exome project was designed to determine which genes really are associated with disease that we really need to target in a clinical assay. And how do we improve the technology, the technique, the reagent that we're using to better cover those genes? And so what we've done is both create a highly curated gene resource and a technically optimized assay to better cover these genes that we know are associated with human disease. And to briefly demonstrate the process, this is a flow chart that shows what happens when you go, to briefly demonstrate the process of how we get from variant calls, every place a patient is different from the reference, to making, to identifying variants that are phenotype related or may fall in the category of incidental findings. And so you can see this diverges right here, starting with the phenotype of the individual, and this is why it is so important that we get good medical records. We can use bioinformatics techniques based on a patient's clinical presentation to determine what genes we should be shortlisting or specifically looking at that may be associated with disease. We take these thousands of calls that get made from somebody's exome and use our own in-house scripts to filter out what we think are good candidates for being potentially associated with disease, either very rare variants, variants that have previously been associated with disease, and combining this with phenotype, we can make a short list of these variants, and then we go through and evaluate these based on a patient's clinical phenotype. Depending on whether a variant may be associated with something phenotype related or non-phenotype related, we can divide that based on what was ordered for that patient, whether incidental findings need to be reported, whether carrier status needs to be reported, or whether we can go on and say this either makes a diagnosis for the patient or is a variant that creates suspicion for a particular diagnosis that a physician can then work from. So before I turn this over to Lindsey to demonstrate how cases use this process, how we've used this process in real life cases, I want to just take a moment to point out, to discuss EGL's commitment to data sharing. We have been an early supporter and submitter to the ClinVar project. If you're not familiar with ClinVar, you can find information on the NCBI website. ClinVar is a database into which clinical laboratories can submit their data and their variant classifications. We truly believe that we will make better interpretations of sequence variants working together as a community than a laboratory will on its own. To this point, up until now, we've submitted over 7,000 variants with classifications to ClinVar. Many of these variants have been seen only at EGL. Some have been classified by EGL and another submitter. We've had a high level of concordance between our classifications and others, and then where we did have discordant classifications, something perhaps a variant of unknown significance versus likely benign or benign, we've been able to work with other laboratories to resolve those discrepancies. The discrepancies have mainly been, the source of most of those discrepancies is when a variant was evaluated. If a variant was evaluated by one lab 3 years ago and by another laboratory a few months ago, there's often new information that explains one of those two classifications. In addition to submitting our variants to ClinVar, we have also taken our internal data from our MVAR system, which includes variant information about particular changes, what gene it's in, what the coding changes, the amino acid change, our own review data, and publish that to our website through a tool called MVClass. We've pulled the gene, the exome, the genomic position, what the change is named, our current classification, the date it was last reviewed, as well as added a functionality to ask a question or request a review of a particular variant. This tool is available from our website. You can search for a gene that you're interested in. Automated searches are allowed, and data can be downloaded in a CSV file for those with their own databases that prefer data in that format. We know that the community is using this data. We've had hits to MVClass from 48 states, as well as 78 countries. And these hits can be curators of databases that are downloading data. They can be individuals that want information about a particular variant. And from there, they can start a discussion with us about how we've reached the classifications that we've reached. So I'm going to turn this over to Lindsey so she can tell you about our EmExome test, the testing options, and some interesting cases that we've seen.
All right, so I'm going to start by going over our options that we have for exome. We have two main options for exome sequencing. Those are family trios and Proband Only. We'll go into some of the differences between those in a couple of slides. And then we also offer an EmExome array, which offers deletion duplication analysis for the genes that are on those sequencing panels. On the EmExome sequencing. So it's really designed to complement those two sequencing options. So what's the difference between the Proband Only and the trios? When we get a Proband Only sample, we only sequence and analyze that Proband sample. Parental samples can be sent along with that, and we can sometimes use that for targeted confirmation of variants that we find that we feel could be phenotype related, so related to that patient's phenotype. But secondary findings won't be reported in the parents on these because we're only using those samples for confirmations of phenotype-related variants. When we get samples for trios, we're sequencing the Proband sample as well as the maternal and paternal samples at the same time. But we're only analyzing them in reference to that Proband sample. So we do have mom and dad's information, but we're only looking at those calls made in the Proband. And then secondary findings can be reported in the parents if they're requested, but we're only once again looking at those findings as seen in the Proband. So for example, if the mom was a carrier for cystic fibrosis and and the Proband did not inherit that change from the mom, it wouldn't be reported. And one of the common questions we get is, well, why? Can't you see if mom has that? And we said, well, yes, but the point of this testing is really to diagnose the patient. So we're really only looking at the Proband sample because we're trying to figure out what's causing their phenotype. Some of the advantages of ordering trios, because we're able to see the calls from all three of those individuals, the accuracy of the variant calling is improved, and we're also able to make calls in low coverage areas. It also allows us to make direct observation of the inheritance pattern. So we can instantly see if the Proband has a variant and it looks de novo. So Proband has that variant and mom and dad do not have it. And a gene that we know is associated with a recessive disorder, we're instantly able to see if those variants are segregating. So if one variant came from mom and the other variant came from dad, we might be more suspicious of those variants as opposed to if we saw both of them coming from the mom. Also with the trios, you have the option to add an EmExome boost. This boost option corresponds to one of our next-gen panels. And these panels, basically the purpose of the boost is for the genes that are on that panel, if there's areas of low coverage, so if we're missing some of the sequence in those genes, we'll go back and fill that in using Sanger sequencing so that we get the most coverage for those genes of interest. These are just some frequently asked questions that we get about ordering our exome sequencing. So what happens if they want to order a trio, but one parent's unavailable? Or if both parents are unavailable, but there's either a sibling or an affected grandparent that might be available that could help with interpretation. So this is an option. We have done this in the past, but we always ask to call and talk with a lab counselor before sending this, just to make sure that we know what we're getting when we get the sample in, and to make sure that the most appropriate people are being sent to be a part of the testing. Another frequently asked question is if there's another affected sibling in the family, can we add a fourth person to a trio? So that would be basically two probands as well as their parents. We can do this. We have another option listed here for an additional family member. It is an additional cost, but it's very much reduced. Rather than ordering full exome on both patients, it would be cheaper to add the other person as an additional family member, and that person would get their own report as well. So we do have an option for if there's two affected siblings that both want a report for exome. I also want to go over our reanalysis options. So this is mainly for if we have, if you've ordered exome a couple years ago and it came back negative or uninformative. These are good options for if you want to have that data relooked at now, because we are constantly adding genes that are now associated with disease, so we can relook at that data. So the first one up there is our clinical exome reanalysis. That's the test code in parentheses there. So that's just a bioinformatic reanalysis of that Proband's data. And we're able to look for new genes that have been associated with disease. And we're also able to incorporate new phenotype data. So if the patient has new symptoms, we can incorporate that into our analysis. The second option is our trios upgrade option. So initially when we were offering exome sequencing, we were only offering Proband only. Trios wasn't an option until later. So if this was the case, if you ordered exome a while back and only had the Proband only option, or if even you had to order Proband only because parents weren't available when you sent for testing, we can offer this trios upgrade, where now we'll go ahead and sequence the mom and the dad as well, and then look at their data with the reanalyzed Proband data. And we have been able to resolve cases that were previously negative by doing reanalysis, so it really is a worthwhile option. This is just a screenshot from the website. I used the trios as the example. You'll see on the website there's a description of the test itself, as well as test codes, turnaround times, and CPT codes. At the bottom of the information on the website are the specimen requirements and how to order this. So we do require whole blood samples on both the proband and the parents if we're doing trios. In addition to the blood samples, we need the medical records or some clinical summary notes for the patient. That way we're able to tell what's phenotype related and what's not. And then there's also, we need to sign consent form, and we'll talk more about the consent form in a couple of slides. But the consent forms are located on the test requisition, and there's a link to that requisition at the very bottom of the website. I was going to include some screenshots from the requisition, but we're actually currently now in the process of updating it to hopefully make it a little bit more user-friendly, so I wanted to hold off on showing what it looked like because it should be even better very soon. So these are our consent options for mandatory disclosures. So these are findings that will be reported in every case. The first one are the diagnostic findings related to phenotype. So this is why the testing was sent. We're trying to diagnose the patient. Variants that we'll report in this category are either pathogenic, likely pathogenic, or variants of unknown significance. We'll also report diagnostic findings that are not related to phenotype if it's childhood onset. So perhaps we have a very young child and they just haven't developed these symptoms yet, but they will be diagnostic in the near future. Variants in this category will only be reported if they're known to be pathogenic or likely pathogenic. So variants of unknown significance won't be reported for that. For optional disclosures, we have an opt-in policy. So unless the patient or the patient's parent specifically requests to have these reported, we won't report them. And for all of these categories, only things that are known pathogenic or likely pathogenic will be reported. Our four main categories for this are carrier status for recessive conditions, pharmacogenic variants, which wouldn't necessarily be disease-causing, but could affect the way you metabolize a certain drug. We also have two categories of diagnostic findings that are not related to phenotype in adult onset disorders. The first one are adult onset medically actionable disorders, such as some of the hereditary cancer syndromes. And then the last one is adult onset that are currently not medically actionable. So something like Parkinson's or Alzheimer's would fall into this category. And we won't report anything not medically actionable in an adult onset disorder in any patient that's under the age of 18, but this can be requested later. All right, so that's basically the overview of how to order it and what all of that looks like. Now we're going to switch gears and talk about some interesting cases that we spoke about earlier that really highlight some of the successes and limitations, and I'll point out sort of why we picked each case as well. So for the first case, this was sent as a Proband Only sample. It was a 2-year-old girl with severe developmental delay and some other sort of nonspecific findings, the hypotonia, the constipation, some dysmorphic features. She also had an older sister who was similarly affected. So on exome sequencing, we found a nonsense change in NGLY1. You'll see here, the proband was found to be homozygous for this. We did targeted testing in the parents as well as her affected sibling. The affected sister was found to also be homozygous, and each of the parents were found to be carriers. So this gene encodes the enzyme N-glycanase 1, which is involved in the degradation of misfolded N-linked glycoproteins. So at the time, there had only been one paper which had reported this variant, and not even this variant, but this gene. So this paper described a child that had exome sequencing. The child had developmental delay, multifocal epilepsy, involuntary movements, abnormal liver function, and absent tears. There were 2 variants reported in this child. One of them was the variant that we saw in our patient. The other was a frameshift variant in this gene. So at this time, with only one paper out there showing that this gene could possibly be associated with a disease, it wasn't really enough for us to say definitively that this could be a gene associated with disease rather than a gene of unknown significance. So this is what led us to reaching out to some of our colleagues at other laboratories and seeing if they had patients that had changes in this gene as well. And this led to a large collaboration, as you'll see on this paper, of we were able to find 8 affected individuals total. So between all of ourselves and all of these colleagues, we've identified 8 individuals that were affected with similar presentation to our patient, and were also found to have changes in this NY1 gene, with the variant that was identified in our patient as being the most common pathogenic variant. So this information, because of this large collaboration, we were able to now say that this gene is something that can be associated with disease, and we were able to report this variant as diagnostic in our patient because of this published data, because of this large collaboration. Without this publication, the variant would have remained just a variant and a gene of unknown significance, or goose. And as Lori described previously, any variant that we find in a goose automatically has to be a goose, no matter what it looks like, if it looks to be truncating or not, because we don't really know what the impact of variants in that gene will do. This is a case that we wanted to highlight for a couple of reasons. One, it shows once again why that data sharing is so important. Because it was only because of the large collaboration we were able to show that this gene was truly associated with disease and report this. Also, it shows the importance of adding those genes of constantly curating so that we can potentially add genes that used to be of unknown significance over to our genes associated with disease category. So if this had been even done a few years back, it may not have been reported, but then if it had been ordered for reanalysis later, at that time we may have noticed that. Those were the 2 key points for this one. The second case we're going to talk about was another Proband Only case. It was an 11-year-old female with developmental delay, hypotonia, seizures, wide-based gait, abnormal posturing, some dysmorphic features, and an abnormality on brain imaging. On exome sequencing, we identified a nonsense variant in the ASXL3 gene. Over here, we just see the next-gen data. And then on this side, we Sanger sequenced that, and that's, second too fast. The Sanger sequencing in one particular, for that, just to confirm that variant. The ASXL3 gene is associated with a dominant disorder. Variants in this gene occurred de novo. There's been about 6 reported cases. The title for this syndrome is Bainbridge-Roper syndrome, but you'll also hear it called Boring-Opitz-like syndrome because the phenotype features overlap strongly with those of Boring-Opitz. They also have severe psychomotor retardation as well as feeding problems, certain dysmorphic features that are common, such as the arched eyebrows and anteverted nares. And then some of the typical Boring-Opitz syndrome phenotype we don't necessarily see in patients that have these changes in ASXL3, so they don't have that typical posturing or the typical trigonocephaly. So this is just a highlight of the 6 variants that have been published at this point in HGMD. You'll see they're all truncating variants. There's 2 nonsense variants that have been reported, as well as 4 frame shift. And these are pictures from one of the publications, actually I believe it's the first publication for this particular gene. So this is just showing some of those common facial features again. So we see the thin arched eyebrows as well as that high sloping forehead. And at this point, after finding this variant in this patient, we could see some phenotype overlap with our patient. So we had sent this paper to the clinician to try to get their feedback and see, we found this variant, it looks suspicious in this gene. Do you feel like this could be something going on with your patient? And she was able to give us feedback that said, after looking at the paper, looking at the description, and really she went through and enlarged all of the images in this paper and was able to tell us that this did seem to have a lot of overlap with her patient, and this could really possibly be the answer for their patient. It did seem to match. So because of her additional input, we went on at that point to sequence the parents, and both parents did not have that change. So it does look de novo in that patient. And because of this, we were able, between knowing that this was de novo in the Proband, as well as the clinician's information, we classified this as likely pathogenic, and we're able to use this for a diagnosis for the patient. For case 3, this was a trios case that was sent. There was a 12-year-old male that had myopathy, muscle pain, some gait impairment, as well as facial weakness, ptosis, general hypotonia, feeding difficulties, some of the other features that are listed here. I won't go through them all. Mom was found to have arthritis and hip problems, but otherwise the family history was fairly non-contributory. On exome sequencing, we identified a missense variant in the MuSK gene, which is associated with congenital myasthenic syndrome 9, associated with acetylcholine receptor deficiency. So this disorder is recessive. Its common features are facial weakness, ptosis, muscle weakness. They can have respiratory insufficiency, neonatal hypotonia, muscle weakness, and then there are specific findings on muscle biopsies that can be analyzed as well. For this particular variant, it was classified as a variant of unknown significance. It had been reported in the general population, but was at a fairly low frequency. It had been reported twice in the literature. Once it was reported in trans with a frame shift, and they were able to do some functional studies as well. So they showed that this particular variant didn't affect the catalytic kinase activity, but it did show some diminished expression, which led to downstream effects like decreased acetylcholine receptor aggregation. And they also did expression studies in both the patient biopsy and a transected mouse muscle. One of the things that we were looking at here is they did some of these functional studies in both the missense variant as well as that frame shift. The frame shift, it wasn't just a decrease, it knocked out the entire expression of this, whereas this particular variant, which just showed that decrease, not an entire lack of expression. This patient also had a brother that also was found to have these two variants, the frame shift and this missense, and he had died at birth from respiratory distress. The second time this was reported was in two other affected siblings. They found this missense variant as well as a frame shift variant. These two individuals had tongue weakness and atrophy, ptosis, and then some mild facial and leg muscle weakness. And I don't believe in this paper segregation studies weren't performed, so they didn't give information on if mom and dad were both carriers for us to know truly if this was segregating with disease in the family. So at this point, it was a variant of unknown significance. We reported it out on exome sequencing, and the clinicians felt that this could be a good phenotype fit for their patient, but with just the one variant of unknown significance and a recessive disorder, they went ahead and ordered a deletion duplication panel. So it was one of our congenital myasthenic syndrome panel that includes this MuSK gene. When we ran the deletion duplication analysis, lo and behold, we found a deletion that encompassed exon 6 of the MuSK gene, which is a pathogenic deletion in this gene. So now we are currently awaiting testing in the mother to see if she happens to be, because we want to make sure they segregate in the family. So we want to make sure that mom has that deletion and then dad has that variant of unknown significance. And if these are shown to segregate, we'll most likely reclassify that variant to likely pathogenic, which could be the diagnostic or the diagnosis for this patient. So this was an important case that we wanted to show just because it highlighted some of the limitations of that sequencing. So as we talked about before, large deletions and duplications won't be detected on sequencing. So the exome sequencing results gave us the right direction to go in and indicated further testing that needed to be done, which then led us to, at this point, probably lead us down to a diagnosis for this patient. The last case that we're going to go over was a Proband Only case. It was a 13-year-old girl with a clinical diagnosis of Schwarzman-Diamond syndrome. Previous testing had found a pathogenic variant in the gene associated with that syndrome, but she also had other symptoms as well that they thought weren't properly explained by that diagnosis. So she was short, she had failure to thrive, she also had hypothyroidism, neutropenia, multiple bacterial infections, and a history of lymphopenia with combined cellular and humoral immune deficiency. On exome sequencing, we identified two variants in the RAG1 gene. Both were truncating. One was a frame shift, the other was a nonsense variant, and both had previously been reported in the literature in individuals that had severe combined immunodeficiency, and they were both of a type expected to cause disease. This is just a brief overview of the phenotypes that are listed with this particular gene in OMIM. All of them have some level of immunodeficiency, which seem to fit with our patient's phenotype. But when we were looking through the NGS data, we didn't see that previously reported variant in SBDS, which the clinician had told us had been done at 2 different laboratories, so at Duke and at GeneDx. They identified this variant, and it's kind of small in here, but hopefully everyone can see it. The reference sequence here should be a T and an A, and the variant that was found in this proband should be, instead of the T and the A, there should be a C and a T. And here's the next-gen reads for that particular spot, and you'll see all of them are that T and the A. We don't see the T or the C and T anywhere, which made us a little suspicious. So we talked to the clinician. They sent us over all the reports for that particular variant, and then we wanted to go ahead and send it down to Sanger because both the sequencing performed at Duke and GeneDx were done by Sanger. And the minute we sent it down to Sanger, they let us know that there were some issues because there was a pseudogene with this. And as we previously discussed, NGS is not a great platform to pick up things that have known pseudogenes. So these are actually the reads from the pseudogene. So here we see that C and that T that we were looking for earlier that we weren't seeing. So really the problem with NextGen is when it's placing these calls, it can't tell, because of the high homologous regions between the gene and the pseudogene, it maps, it can't always tell what to map. It can't tell if it's mapping to the actual gene of interest or to that pseudogene. So this was the Sanger for this particular patient, and we did identify that change that had been previously reported. So we see here, there's the T and the A that should be there on the reference, and the proband, we see that they're heterozygous for that C to T change, or C and T change. Because we sent that for Sanger, we sent the RAG1s for Sanger as well, and we sent not only the proband, but the mother when we did the Sanger confirmation. Both those 2 variants in RAG1 did confirm. The mom was found to be heterozygous for one of them, which suggests to us that these are on opposite alleles in the proband. The father was not available for testing. And it did confirm the SBDS variant in the proband, and mom was negative for that one. The last call down here was just when we did Sanger sequencing. It was another call that was picked up in this region as a silent variant that was not reportable. I think, yeah, that's the last for that one. So that's just another, we chose that one because it's important to know, it was diagnostic for the patient. Those RAG1 variants were able to give her the diagnosis of SCID, and I talked to the clinician even last week, and they were really excited to get this back because they felt the previous diagnosis just wasn't enough for this patient. But it is important to highlight that, what was previously known wasn't able to be detected by NextGen and really did require that Sanger sequencing in order to pick that up. So that's the last case. These are the acknowledgements.
And we would like to take questions, and we don't seem, let me get back on that thing. Okay. Yeah. We want to get back to the chat where we can, if you'd like to ask a question, you can type it into the chat window at the bottom, and hopefully we'll be able to see it. Presentation back up to there. Yeah. If there's any questions, we can take that. We had a question come in about the advantage of a boost, and is that part of this medical and EmExome design as opposed to a regular exome, or what is the advantage of the boost? Lindsay, do you want to?
Sure. Okay. So the advantage of the boost,
what is the boost?
So the boost, it does correspond to one of our next-gen panels. Most of them are options, with the exception of a few. There's a full list of all of the boost options on that testing requisition. And the real advantage to that is when we do the exome sequencing, we know there's going to be some areas of low coverage, and there's some things that are going to be missing. That's just a limitation of the platform. And with the boost, it allows the clinician to say, these are genes that I'm interested in. So, I don't really have a good phenotype in mind for this patient, but I think it might be something neuromuscular. So I want to add the neuromuscular boost to this. And that way we're able, we pull these genes aside, we look at them specifically as things that have been targeted by the clinician. And if there's areas of low coverage, we'll go back and then Sanger those. So you're getting as much information about those genes of interest as possible.
Are there any other questions? Give people just a moment here. There is a section for questions as well as a chat. We're able to see both. Oh, maybe move down here. Hang on, we're figuring out our questions. Let's see, sorry, we can see one line of the question at a time. Hang on just a minute. Let me see if I can get this bigger.
Yeah.
Oh, okay. The question is, would current combined SNP oligonucleotide arrays have detected the small deletion? Yes, I know such small CNVs are usually disregarded. However, I wonder if the density of the SNP markers would have been sufficient. So this is an excellent question, and it's true that SNP arrays can detect small deletions and duplications, and of course that ability to detect a deletion or duplication is entirely dependent upon placement of those SNPs that are included on the array. And in this case, because it was a single exon deletion, it was quite small, a few hundred bases, it is unlikely that the SNP array would have had sufficient coverage to detect this. There are cases where deletions, say, in the DMD gene, which is very large, and the deletions can be large, do get picked up by cytogenetic arrays, by SNP arrays. In this particular case, it's unlikely that that MuSK exon deletion would have been detected by a SNP array. However, it would have been detected by, it was detected by this gene-targeted array, and it would have also been detected by the exome array. It's a good question. Let's see if we have others. Will the recording of the session be made available to the public for downloading? Yes, it will be available, and I'm not sure about the CME credit.
I don't think we registered for that.
I don't think so. Let's see, do we have other questions? I think we've answered the questions that were on here. Oh. Oh.
Yes.
Okay. All right. We'll check the chat. Okay.
Nothing there.
If there are no additional questions.
One just came in.
Yes, this webinar will be available afterwards. We will make it available. I assume attendees will be given instructions on how to access it. All right, thank you very much. Just shut down, but let's, okay, hang on, unmute.
Yeah.
We will be sending the recording out to everyone who signed up tomorrow. So if you were signed up, you will get instructions for getting a recording of this.